Social Sciences Forum. I'd like to welcome you to today's talk by Professor Reischauer. This is the last talk of this semester. We're putting together the series for next semester, and it promises to be, I think, even better than this semester, if you can believe that's possible. And we'll have flyers as well as our website put up probably right after the new year. And we hope we'll see many of you back for our spring sessions. Before going on to introduce Bruce Stewart, who will introduce the speaker, I'd like to express thanks to a number of people who helped organize the series this semester, including Chris Lindemeyer, Chair of the History Department, and Delana Gregg of the Sondheim Scholars Program, and many, many others who I won't name now. I'd also like to thank the co-sponsors of today's forum, along with the Social Science Foundation. This is co-sponsored by the Hilltop Institute and the joint UMBC program, doctoral program in gerontology. So thanks to both of those organizations for their support. At this point, I'd like to introduce Dr. Bruce Stewart, who is an economist in the Department of Pharmacy at UMB, as well as a faculty member in the joint gerontology program, who will introduce our speaker.
Thank you very much. It's just great to see a crowd like this on a nasty December afternoon, and I'm just delighted that our speaker was able to make it through an accident on 95. You might wonder why I'm here. I have a real privilege of knowing Bob Reischauer through work that we were involved together in the Medicare Payment Advisory Committee, and I'll think about that in a minute, but I want to give you just a very brief background for somebody who is a internationally known expert in health policy and social science research. He currently is the president of the Urban Institution, which is Urban Institute, which is one of the most important social sciences institutions, as you heard from your president just a few minutes ago, in the United States. He has held that position since 2000. He is a political scientist, received his bachelor's degree from Harvard. He has a doctorate in economics from Columbia. He had two stints with the office, with the Congressional Budget Office, and I'm sure you all know about CBO, right? Okay, CBO scores things, and they can become quite unpopular in Congress. And during a previous health policy debate during the Clinton administration, I don't know whether it was Bob or his minions, but earned the sobriquet of skunk in the garden party, because he came up with some numbers that were not appreciated by the Democrats in Congress. And he's famous for that, because every CBO director since then has been given a stuffed skunk upon his taking his position. Well, I got to know Bob when he was on the as I said, on MedPAC. I joined in 2007, and Bob called me and congratulated me for being appointed to this commission, which does a lot of things with Medicare. And he said when he was first appointed in 2000 that he really thought he knew the Medicare program. After all, he'd been deputy director of CBO and then director of CBO. He worked as an analyst and a researcher at the Urban Institute and other places. And he said he had a real education in terms of the complexity of the program after he was there, and he warned me about that. And I'll have to say that is exactly right. Is that you may think you know how something runs, but when you get down into the nitty-gritty of it, and that's some of the hard parts that we'll talk about today. So Bob, it's a real pleasure to welcome you to UMBC, and we look forward to your remarks.
Thank you. It's a real pleasure and an honor to be at this campus of this great university. Freeman Hrabowski is a member of my board of directors at the Urban Institute, and so I pay close attention to how your chess team's doing and other important aspects of this university. But I really take my hat off to both Freeman and all of the people on the faculty, the administration, and the students at this university. You're really a great educational institution, and it's an honor to be here. Mark said that the program in the spring was going to be even better than the program in the fall, and so that sets the bar pretty low for me. I can make him very prescient by giving a just terrible talk, and so I will try and not to disappoint.
Bob, if someone could turn the microphone up for him, it's not.
Well, I can get that closer, and I have this in here, and I'm not sure this has a volume control. If there's
Marv, I think the volume is on the front.
usually when somebody comes to help you with technology, they're younger than your kids, but this is not the case. Oh, that's at this one, but not this one. Okay, well,
That's it.
I'll stay close. I think, given that my genetic material is going to make that hard. As Bruce said, last spring he invited me to give a talk about health reform at this forum, and we were certain at that time that if we scheduled this for December, everything that was going to happen was going to have happened by then, and I could tell you about it. I went back to my office after this conversation with Bruce and jotted down two possible titles for my talk, which is what you see there. The first, Play It Again, Sam, was the title I thought I'd probably use because I thought what would happen is the effort to reform our healthcare system would have crashed and burned, and what I would be here telling you is how the forces of the status quo had once more conspired, as they had in the past, to deny our country what every civilized nation in the world seems to have. The second title I jotted down because I thought, well, there's some chance something actually will happen. And if it does, I will give a talk which is, and now for the hard part, which would focus on how you all thought that the process of enacting the legislation was tough, but that was nothing compared to what it was going to take to implement this piece of legislation. Well, here we are in early December, and we don't really know whether there will be fundamental healthcare reform moving through the Congress. Most of the smart money is convinced that some significant legislation will be sent to the president for his signature. Probably not this year, but almost certainly before the end of February in 2010. The fact of the matter is just too many legislative leaders in the Democratic Party have invested too much in this issue to allow it to fail. And if you believe the pundits, they really don't have a choice because if it fails, it would prove devastating to the Democratic Party in the midterm elections next year. At the same time, sort of the smart money says something's going to happen, and there's this sense of inevitability about it. There are many irreconcilable differences, and no one can figure out how they're going to be resolved or how they're going to be papered over. And then there are a bunch of procedural hurdles that will have to be overcome because to get legislation through the Senate is going to take 60 votes. And then we're going to have the legislation go, or my slides are not in order, so we're going to have to go to a conference committee, and in a conference committee, the two House and the Senate versions are going to have to be crafted into a single bill. And what we all know is that many important members of Congress have drawn lines in the sand on different issues and said they aren't going to budge unless their version is reflected in the final legislation. So we have a very, very uncertain situation facing us. What I thought I'd do is, in this situation, focus my remarks on the major points of contention that have to be resolved before the bill can be sent to the President's desk, and then discuss a bit the formidable challenge that will face us in trying to implement whatever it is that gets enacted. But I want to start with some background, because all of you, unlike Bruce and myself, don't live and breathe this stuff day in and day out. And so we'll have a bit of overview of the situation. First, let me lay out what are the three primary objectives of health reform. The first of those, of course, is to reduce the ranks of the uninsured. We have close to 51 million Americans, or residents in the United States, who lack insurance, and that's about 19% of the non-elderly population, which, for the world's richest country and the world's country that devotes the highest fraction of its total resources to health care, that's really an outrage. The second objective is to moderate the growth of healthcare spending, both in the government sector and in the private sector. It's been increasing at roughly 2% a year faster than our economy has been growing. And this excess growth, the experts tell us, is what makes the budget path, which we are now on, unsustainable over the long run. We have to bring down government spending on health care if we're ever going to have a hope of bringing our deficits under control. The rapid growth of healthcare spending is also the primary explanation for why American workers have seen their cash wages stagnate over the last decade. There have been pretty healthy gains in worker productivity over this period, but those gains in productivity haven't, as your economics theory class will tell you, should be, translated into higher cash wages. Instead, they've been absorbed by the ever-rising costs of employer-sponsored health insurance. Final objective of health reform is to improve the quality of health care, which is badly in need of more than just a tune-up, notwithstanding the fact that we all look at each other and say to each other, Americans, we have the best health care in the world. We usually say that because we haven't looked elsewhere. If you look around the world, the unpleasant truth is that on many dimensions, access to physicians, whether you can get medical care on a weekend or an evening, affordability, health outcomes, care coordination, IT, integrated care, Americans who are insured get pretty mediocre care. And those who are underinsured or uninsured get rather dismal care. So here we are again, engaged in a Herculean effort to transform our healthcare system. I think you've all heard many times that among Democrats, at least, in the House and the Senate and in the White House, there's a large amount of agreement. There's a consensus on what healthcare reform should entail. And let me go over sort of the 6 areas where there seems to be general agreement, at least among Democrats. The first is that health reform has to include an individual mandate, which involves a requirement that everybody go out and obtain health insurance that meets certain minimum standards. This requirement can be fulfilled by having an employer-sponsored plan. You know, your firm provides you with insurance, or your union does. That's the case for roughly 65% of Americans today. You could get it through a government program like Medicare or Medicaid or the VA, or you can get it by purchasing insurance as an individual from an insurance companies. In the reform system, if you didn't comply and go out and get insurance that was of certain minimum protection, a penalty would be imposed on you. And the only exceptions here would be undocumented immigrants, followers of certain religions that prescribe health care, and those for whom the requirement of purchasing insurance would impose a unreasonable financial burden. And we'll talk about what that means a bit later. Second consensus area is the requirement that businesses, to some degree, share in the costs of their workers' insurance, and those that don't offer insurance, meaning those companies, be subject to some kind of penalty. The only exception here would be instances in which the firm was too small to impose the requirement on. Too small is really a euphemistic reference to too politically strong for us to exercise this discipline on. Third consensus component of reform is that we need to create some kind of marketplace labeled exchange where those people who don't have insurance, or small firms that have a hard time finding affordable insurance, can go and shop and find an insurance policy that best meets their needs from a menu of rather standardized options. Currently, the non-group market, which is where individuals who don't have employer-sponsored insurance go out and find their insurance, is largely an unregulated jungle, containing a confusing and complex and non-transparent array of policies that are difficult to compare, confusing, and often quite limited in their coverage. Available policies tend to exclude coverage for pre-existing conditions, to be extremely expensive for those with higher than average risk, to have limited coverage and high deductibles, and be subject to cancellation or huge premium increases if your health status changes. Small group market, which is where a firm with 10, 15, 25 folks working for it go to get their insurance, isn't a whole lot better, and by and large is really offers very expensive policies, which is not because insurers are evil, but because the marketing cost to go out and sell insurance to small groups, or to individuals for that matter, is very expensive, and the administrative complexities are almost as large for a small plan as for a huge plan. The exchanges that would be created by the reform legislation would set rules which would offer uninsured individuals and small firms the kind of assurances and protections that are available now mostly to large firms and government insurance. The plans offered would fall into 3, maybe 4 standardized types, so you wouldn't have an infinite array of possibilities. You'd have some kind of understanding, is it, orange plan or an apple plan or a banana plan, and all the insurers would offer each of those possibilities, and you could understand what you were shopping for. It's important to remember, because there's a lot of incorrect information floating around on these exchanges, that these are marketplaces only for people who are uninsured, people who employers don't provide them with insurance, or people in small, meaning under 25, under 50 employee firms. It represents maybe 10 to 15% of the total marketplace in the country. So a lot of heat, you know, a lot of rhetoric, but this isn't the name of the game, really. The name of the game is still big employers and big government programs. Fourth, because health insurance is so expensive in the United States, imposing an individual mandate would be an unrealistic and unfair requirement because it would be unaffordable for many. And so finding some way of making insurance more affordable is a key element to all of these reform proposals. The consensus approach really has involved three different components. The first of those is that folks with the lowest of incomes, and this means somewhere between people between 0 and 133% of the poverty level, or 150% of the poverty level, depending on whether you're looking at the House or the Senate bill, would be sort of automatically enrolled in the Medicaid program, which is a program currently focused largely on low-income women and children and the disabled, and a program that provides some supplementary benefits for low-income Medicare beneficiaries. In many states where uninsurance rates are high, and you look at a place like Texas, and 1 out of 4 people in Texas doesn't have health insurance, the current Medicaid eligibility levels for that states, and states get to determine who's eligible in terms of income, are low, you're going to get a huge increase in the Medicaid rolls under these bills. Increases as much as 70%, probably in a state like Texas. And just store that in the back of your head for a little while. The second component would be subsidies for individuals above this Medicaid level that would come in the form of tax credits or some payment that would help them pay the premiums for the insurance that they bought in the exchange. So you have to keep in mind that the people who are going to get these subsidies are just the ones who are eligible to buy insurance in the exchange. They aren't the folks who have employer-sponsored insurance. They can be a low-income person working for an employer, and you won't get a subsidy. If you're somebody whose employer doesn't provide you with insurance, you will get a subsidy. And these subsidies go all the way up to somebody 400% of poverty. That is pretty high up, which is one reason why this all costs so much money. It has to be high up because health insurance is very expensive in this country. 4 times the poverty level for a family of 4 is $88,000, a little bit above $88,000. And for a single individual, it's about $43,000. So the people who are getting subsidies of some value in the exchange, some of them will be well above the median or the average income in America. And there's no other way to do this when insurance for a family of 4 costs in the neighborhood of $13,000 a year. The subsidies will phase out as your income rises, and so you'll get big subsidies if you're down around 150% of poverty, and you'll get very, very small subsidies if you're 375% of poverty. But it will require you, as an individual, to pick up the balance of the costs. And I'll talk a little bit about that later. In addition to subsidies to buy insurance, there'll also be subsidies for the lowest income folks in the exchange for their cost sharing. That is, for their deductibles, for their co-payments, for their co-insurance. Because under your plan or my plan, those can be rather substantial, especially if you're talking about somebody with an income of $30,000 or $40,000. Third component of the policy to make insurance affordable is subsidies directed at small firms who offer their workers insurance and provide some contribution themselves. For example, under one of the bills, if a small firm offers insurance to its employees and it goes into the exchange, what will happen is the federal government for the first couple of years will pick up half of the cost that the firm incurs in offering that insurance. The hope is to encourage more firms to offer insurance, and by doing this, reduce the number of people without insurance who go to the exchange and get the full subsidy. And so it's really a cost, it's a subsidy that saves the federal government costs. Fifth consensus component is insurance market reforms that are aimed at sharing risk more broadly and reducing discrimination against those who are in poor health. Among the measures that would be part of the reform system would be guaranteed issue and renewability, which means that insurers couldn't deny you the ability to enroll in their plan because you had some kind of health condition that was likely to be expensive. Employers would have less flexibility than they have now to make you wait a long time for a policy. And while most of you have experience waiting 3 months, 6 months, 30 days before your employer puts you on his plan, there are large retailers who will go unnamed that you patronize that have had 2-year waiting periods to get on their insurance policies. And, you know, while you might think that that's unreasonable, it's a part of our economy where there's a very rapid turnover of employees, and it becomes very, very costly if they're going to do what the Unrealistic does, which is say, you're here today, you're covered with insurance tomorrow. The state of Maryland probably does that for folks at UMBC as well. But reforms would transform all of this and make it much more, in a sense, consumer-friendly and ensure that people had the kinds of protections that they imagined they had when they signed up for insurance. Elimination of lifetime limits and annual limits on coverage, elimination of ability to vary your premiums according to your health risks. Finally, as a factor of particular interest to some of you, is the fact that these reforms would say for unmarried young adults, they could stay on their parents' policies through age 26, which would change things considerably, I think, for people just entering the labor market, particularly in tough times like we're experiencing now. A sixth component that everyone, and this is both Democrats and Republicans, agree is essential are measures that would slow the growth of healthcare spending both in the public and the private sectors. While there are many promising ideas on how we might bend the cost curve, which is what the lingo is, there are really no proven mechanisms for doing this, and those that look to be the most promising are often those that are the least politically acceptable. Both of the reform bills before Congress are filled with pilot projects and demonstrations that will test cost-reducing potential of various ideas, many of them ideas that have been championed by the Medicare Payment Advisory Commission that Bruce has played a role in formulating. Accountable care organizations which could manage and coordinate patient care, medical homes which would put a greater emphasis on primary care, hoping to save the money we now spend on specialists, bundled and episode payments which would lead to efficiencies in the delivery of care, and so on. There are just a whole lot of things like this in these bills. There are also many provisions that would cut Medicare payments to providers, and there's also a number of initiatives that would increase knowledge in ways that might lead to more value-based purchasing of health care and more innovation. There's attempts to change the incentives that face purchasers and the deliverers of care. Among the former is a very important step in the Senate bill, which would impose an excise tax on very expensive insurance policies, trying to get people to forego what is now a tax advantage to putting their compensation in the form of health care, health insurance, and transforming it into something else. The final area of broad agreement involves the three fiscal constraints that the President has imposed on this process, and the Congress has kind of reluctantly gone along with. The first of these constraints was that the spending on subsidies and benefit expansions and other things shouldn't exceed $900 billion to $1 trillion over the next 10 years. The second was that after we count the spending cuts and the new taxes and the new fees, the measure should not add at all to the deficit over the next 10 years. And finally, there's a constraint that the bill should hold out at least a reasonable prospect for reducing the deficit in the period beyond 2019. In other words, the second, third decades of this new reform system. The reason why this last constraint is important is because the bills going through Congress don't begin providing the benefits, the big subsidies, the new benefits, until 2013 or 2014. The new taxes, the new fees, the cuts in Medicare payments to providers all begin in 2010 or 2011. So what you're doing when you say shouldn't add to the deficit over the first 10 years is you're comparing 10 years of revenue or savings against 6 or 7 years of benefits. So you could meet that and still create a world which in the 11th, 12th, 13th years was something of a disaster. Well, so we have this general agreement here of provisions that both sides of Congress believe are important and worth pursuing. The process now is that if the Senate passes a bill, it will be merged with the House bill in what's called a conference committee, and then the final product will be voted on by the House and by the Senate. But for that compromise to occur, for the conference committee to reach an agreement on a single bill, they're going to have to resolve a lot of very, very contentious issues. I've picked out 6 of them, I believe, which are not down in the weeds, nitty-gritty, but large areas of difference. The first of those is the generosity of the subsidies. This is a chart which shows you the percentage of a person's income or a family's income relative to the poverty level that will have to be contributed by the family towards its own insurance. And as you can see from this chart, there are differences between the House and the Senate, except during the range between 225 and 325% of the poverty level. The Senate is less generous than the House for low-income folks. The higher the line, the less generous you are, the more the requirement is to contribute money towards your premiums. And the reverse is true when you get up to higher income levels. The differences between these two lines amount to about $500 at their largest point for individuals and $1,000 for families. If you were to go through all the permutations and combinations where people living in different parts of the country and different ages, which can be charged different amounts, you might double or even triple that $500 and $1,000 a year. They're going to have to decide on a common set of subsidies and one that doesn't greatly increase the costs. The second area of dispute involves how severe to make the penalties for failure to comply with the individual mandate. Some believe that penalties have to be large, or else a significant number of the folks who don't have insurance, particularly the young and the healthy, who aren't eligible for a big subsidy because their incomes are too high, might just decide, you know, I'll go without insurance if the penalty for doing so is relatively small. Others think that if we had a reform system like this, there'd be a cultural shift and everybody would understand that it was their responsibility to go out and get insurance, even if from their own narrow self-interest it cost them something to reduce this risk over and above what they expected their health care needs to be. The Senate bill has very low penalties, ones that in the end are about $750 for an individual or $2,200 for a family, but they start out at $95 and $285. So you don't have insurance the first year, you're a single person, you have an income of $40,000, so you aren't going to get a subsidy, and you'd have to pay $95. And that would look a whole lot better than the $3,000 or $4,000 that you're going to have to pay in the exchange for this required insurance. The House is a lot tougher on this, and what it says is, if you don't have insurance, we're going to charge you 2.5% of your income above whatever the income tax threshold is for filing. And so, I mean, if you have a really low income, you don't have to file. So for an individual, you have to have an income above $9,700 to file. You know, it would be whatever your income is above $9,700 times 2.5% that the House would fine you for this. So there's a big issue here on exactly what we're going to do. A more difficult issue to resolve will be the role that employers have to play in paying for their workers' insurance. And here the House bill is much, much tougher. It says if you're a firm and your payroll is bigger than $750,000, you got to provide insurance that you contribute at least 72% for an individual and 65% for a family policy, or we're going to slap you with a tax of 8% of your entire payroll. This is a really, really hefty tax, and almost all firms will say, you know, better to pay the tax, pay for insurance than pay the tax. The Senate, on the other hand, doesn't require the firms to go out and get insurance for their employees, and all it says is, if you don't provide insurance, and if some of your workers end up going to the exchange and getting a subsidy, then you're going to have to pay a penalty. But the penalty that they charge is really quite modest and is well below what it would cost that firm if it went out and began buying insurance for its workers. This is going to be a huge area of contention. I said the next area is sort of, how are we going to pay for this? How are we going to come up with the $1 trillion, the $900 billion that all these subsidies and other expansions are going to take? Here there is some agreement, actually a lot of agreement between the House and the Senate that Medicare cuts in Medicare are going to pay for a huge fraction of the total. Something like half of the total will be financed out of Medicare cuts. Some of those will come from what's called Medicare Advantage, which is a form of Medicare that beneficiaries can choose through which they get their insurance coverage from a private plan. And what Medicare does is it pays a flat amount to the private plan, Kaiser, Aetna, somebody like that, who agrees to take on the Medicare responsibility for this group of individuals. Because we have a very flawed way of determining what these payments are, we've ended up paying the plans roughly 14% more than it would cost Medicare to cover those same individuals through the traditional fee-for-service system. And what these bills do is say, well, we're going to scale that overpayment back and save some money in doing so. In addition to that form of savings, there are a large number of provisions that cut the annual update, sort of the inflation adjustment to payments in Medicare for various provider groups, hospitals, nursing homes, home health, those kinds of things. If you listen to the debate, and actually if you turned on C-SPAN right now, you would see that the Senate is debating an amendment by the Republicans which say, let's take all of these Medicare cuts out. These are going to hurt grandma. The fact is that they aren't. They, by and large, come out of the hides of providers of one form or another, or this group of individuals who's getting extra benefits through their Medicare Advantage plans. But that is an amendment that will be voted on in the next day or two here in the Congress. Beyond the Medicare cuts, the House and the Senate bills are really very, very different with respect to financing, and here is going to be a difficult issue to reconcile. The House bill relies very heavily on the penalties that it imposes on those firms and individuals who don't get coverage, and that brings in a whole lot of money. It also imposes a 5.4 percentage point income tax surcharge on individuals with incomes over $500,000 and couples with incomes over $1 million. The Senate, on the other hand, relies on fees which it imposes on insurers, device and pharmaceutical manufacturers, and others. It hikes the Medicare payroll tax, the HI tax, which is part of FICA on your wage returns. for people with earnings over 200,000 for individuals or families with combined earnings of over 250,000. And it imposes a 40% excise tax, as I said before, on premiums in excess of $8,500 for an individual and $23,000 for family policies. You can see from that that all of the financing for the Senate bill comes from the health sector. It's giving a whole lot of money to the health sector and it's taking a whole lot out of it. The House, on the other hand, half of what it's getting comes from the general tax system. It's the tax on the millionaires. And there are many people who had hoped that that revenue source would be available for reducing the deficit rather than providing health reform. I'm going down these in list of in order of difficulty, really. The next is the social issues, abortion and undocumented immigration. And here, it's going to be very, very tough to reach a compromise. The House bill, as you all know, has a stronger restriction about using public funds directly or indirectly to fund abortions than the principles that have guided federal policy for at least the last decade and a half. There are many people in the House and there are many people in the Senate who believe we should stick with the current policy and seem ready to go to the mat on that. The question with respect to immigrants is whether uninsured, undocumented immigrants should be allowed, as they are in the Senate bill, to use their own money to go to the exchange and buy health insurance, or whether they should be denied the ability even to pay 100% of the costs for insurance. And the House bill says you can't do anything, and the Senate bill is more lenient in that respect. Lastly, and probably the most contentious, is the question on whether there should be a public option. That is a government-run plan, which those who buy their insurance through the exchange could choose if they thought that was the best plan. Advocates of a public plan argue that it will make health insurance markets more competitive and lower premium costs and keep the private sector more honest and ensure that the private companies adhere to the regulations and rules of the new exchanges. The fact of the matter is that insurance markets, particularly those for individuals and small firms, are highly concentrated in many states, and so you have just one or two or three insurance companies dominating the market, and the fear is that the same might happen within the exchange, and so it would be desirable to have a public plan in there. Opponents of the public plan fear that even if it's restricted to the exchange, it will, over time, end up controlling, gobbling up a larger and larger fraction of insured lives, and it would represent the first step down a long road towards socialized medicine and government control of health. They point out the many advantages that a strong or robust public plan could have. It wouldn't have to generate profits the way Aetna or United Health does. It could convince Congress to provide it with emergency subsidies when going got tough. It would not need to hold reserves because it would have federal government behind it. Medicare doesn't hold any insurance reserves the way a private plan does. It just would dip into the Treasury if it needed to. It could borrow at low rates from the Treasury and therefore have an advantage. It could set provider payments administratively the way Medicare does rather than negotiate them the way a private company does. It could threaten to providers that say, I don't want to take those rates, that it would withdraw its Medicare and Medicaid business to enforce its administrative prices. Its administrative costs would be low because its scale would be so large. This is the fear people have. These fears aren't unfounded if we had a completely unfettered government plan which was responsive to the political pressures of Congress. But the fact of the matter is that in both of the versions of health reform that we are considering right now, the public plan is shackled. It's restricted in many, many ways, and the whole effort is to make what is called a level playing field. The same rules that apply to the private sector plans in the exchange would have to apply to the government plan. It'd have to negotiate rates with providers. It'd have to repay the Treasury for any startup loans that it got. It would have to have insurance reserves. It would have to adhere to all the rules and regulations that the private plans did, and all of its costs would have to be paid for through premiums. Notwithstanding all these constraints, there are many, as you know, in Congress who strongly oppose any form of a public plan, and the search that is underway right now is how can we get something called the public plan in the bill while retaining 60 votes in the Senate. And one possibility is to allow states to opt out. If you don't want it in Arkansas, the state legislature and governor can say, we don't want a public plan. A little stronger policy would be to make states opt in, have to vote to be able to get a public plan. And a third approach, which could be combined with either of the other two, is to trigger the option to say that we won't have a public plan unless certain benchmarks with respect to competition or the rate or level of premium growth are violated, in which case the public plan would ride to the rescue. So those are the big issues that we're going to have to resolve sometime in the next 6 weeks or so if a plan gets through the Senate. Let me close by saying a few words about what I regard to be some of the big challenges that will face reform if and when a bill is signed by the President. And as I said earlier on, in many ways, I think these challenges are more formidable than any that we have encountered so far. The first of these challenges dealing with unrealistic public expectations. It's going to take a long, long time to get this plane off the runway. And I don't think that is going to be fully understood by many Americans. We're going to have a champagne party sometime in February if something's passed, and if it's according to the Senate timeline, it's not going to be till 2014 that the first person gets their subsidy. And that's a long time for Americans to wait. We are not used to deferring gratification. It might be okay to wait if nothing were changing. You know, if you could say, well, you know, we'll just tread water here, live with what we have from now until 2014, and then we'll enter the promised land. But as you know, the health care market is in constant turmoil. Costs are going to continue to rise. The ranks of the uninsured are going to continue to grow between now and 2014. And you know, health reform is going to have almost no impact on it, these things, for 2 or 3 years. We have a president who unfortunately has made a lot of promises in this area, that you have to be very nuanced to understand what he said. And in some ways, what he said was right on the money, but it's not the kind of thing that the American people listened to and understood. For example, one thing he said was, your insurance premiums are going to be $2,500 lower because of reform than they would have been otherwise. And I think to most people it says, you know, I'm paying X thousand, it's going to be X minus 2,500 after reform. Even if that number, 2,500, is right, it is from what your premiums would have been in 2019. And what you don't realize is that your premiums will have doubled by then. He's taken a little bit off, so rather than growing at 7% a year, they're only going to grow at 5% a year. Are you going to be happy? The answer is no. Furthermore, the 2,500 applies to your insurance premiums, but 3/4 of them are picked up by your employer. So 3/4 of the 2,500 is going to go into his pocket, not into your pocket. And if economics is right, a lot of that will filter back in the form of higher wages, but you won't understand that as being the result of healthcare reform at all. Another thing the president said was that if you're happy, you know, with your insurance, and if you're happy with your doctor, fine, you can keep them. There's nothing in this reform that will affect that if you're in an employer-sponsored plan. And that's true. But that doesn't mean you're going to keep your same plan, because your benefits, folks at your firm might decide to change from Aetna to Kaiser. Your doctor might decide to drop out of the network that you were in. All of the same kind of changes that are occurring now will occur at the same pace that they have been going on before. And I don't think that's the expectation of the average American. And so there's probably going to be a whole lot of dissatisfaction. Your employer can decide to make the policy less generous than it was in the past. Your formulary can drop the drugs you were using and substitute generics. All of that will go on just as it has in the past. Another question here is whether we can stay the course once the pain begins to bite. The pain is going to come in various forms. There's going to be some sticker shock. If you look at the second column there, it gives how much an individual in the exchange at various income levels is going to have to fork out of their own pocket after they get their subsidy for health insurance. And these are not small amounts of money. I mean, a family of 55,000, 250% of the poverty level, is going to have to come up with $4,400 that it hasn't come up with before if it's an uninsured family. So while these are not tens of millions of people, there are large numbers of people who, because of the mandate, are going to have to give up buying a new flat screen television or a new boat or whatever because of the individual mandate. What's going to happen then? What's going to happen when we begin cutting back Medicare Advantage payments, and that is going to lead to a reduction in the extra benefits that those participants have enjoyed from their Medicare Advantage program. Many years, MedPAC has recommended cutting these payments back. Many years, the Congress has said no, and it's because they can't take the political heat from the 25% of the population, Medicare population, that is now in these plans. Going to be very, very tough. What are we going to do when all of the cuts occur to Medicare providers. The hospitals get a little less of an update every year. The nursing homes get a little less. They're all going to go to Congress and they're going to scream. Do we have the fortitude to stand behind these decisions? Final issue, is state and federal administrative capacity. This is a huge undertaking. It's much greater really than anything we have tried before. You look at Social Security, you look at Medicare, Medicaid, other big domestic issues, initiatives, and by and large, they're building something in a vacant field. They're putting a program where there was nothing. This is very, very different. This is like completely renovating the building while people are still living in it. You're moving around the existing employers, beneficiaries, producers, providers, and it makes it hugely complicated to do. Notwithstanding the fact that this is a 2,000 plus page piece of legislation, there are huge amounts of decisions that have yet to be made. Some analyst at a conservative think tank went through the bill with his search find component and found that there were 1,697 times in the Senate bill where it says the secretary shall, and it was do something, define something, set some level, et cetera, et cetera. It's going to take many, many people to write the regulations, to set up the exchanges, to figure out how the IRS is going to tell the exchanges how much individual X owes in that premium chart. And we are notorious in this country for not providing the bureaucratic support that's necessary for these kinds of things because it's supported largely by discretionary funding. And the Congress has other interests than making sure that the bureaucracy is efficient and well-staffed. So I think there's a huge challenge here with respect to the states. I told you that a state like Texas might have an increase of as much as 70% in its Medicaid population. You know, how does the state cope with something like that? How do you find providers who will serve those people when you're already having a problem because of your low Medicaid grades? So this will be a huge challenge. I don't want to end on a down note because we are really at a place we've never been before and a place that, quite frankly, I never thought we would be. I don't know if you remember this, but my probabilities at the beginning of the year when the President said he was going to go do this were that it was about 5% that a bill would ever get to his desk. My guess is it's probably closer to 85 or 90 at this point. We are a country that has a long tradition of enacting horrendously flawed legislation and then spending the next decade trying to repair it, and that's what keeps me and all of you busy, is the jobs that are created trying to perfect the imperfect. And so I really think we should all keep our fingers crossed. It won't be pretty. It won't be easy to sustain, but it really is a historic moment for this country to see us at the point most of Western Europe was 55 years ago. Thank you.
Dr. Reischauer has graciously agreed to take a few questions, and I'll let you call on people as you see fit.
Thank you very much. I had the privilege a few years ago to live for a few years in Germany. And Germany has a system that is somewhat similar to what we are talking about here. in that there is insurance required of everybody. Employers provide a certain percent by requirement through the use of privately owned and managed insurance companies, although government regulated. I wonder if you could compare and contrast what we're proposing here with what Germany has, keeping in mind that the technology is essentially identical from one country to the other, and they pay about half as much on a per GDP percentage as we do here in the United States, and have considerably better outcomes.
You know, you could have said Denmark, you could have said Netherlands, you could have said France, you could have said, well,
But I
not
lived in
France, but,
Germany.
no, I know. There are many countries that do it better than we do it now, and do it better than we're going to be able to do it if one of these things passes. The German system is a system of what are called sickness funds largely, and they don't have the complexity of having a Medicaid program and a Medicare program, you know, something for the poor and something for the elderly and disabled. And virtually no other country does that, and we've done it because we didn't do something for everybody in between. And you know, could I press a button? Would I press a button if I had a choice between one of these plans in Germany, the Netherlands, Switzerland, Denmark? Yeah, I wouldn't even give it a thought. You know, the reason, though, that the costs are so different, some of it is the administrative complexity of our system, but a lot of it has to do with the fact that we provide everything that anyone claims has a positive impact on health, no matter whether its marginal value is worth the cost or not, and other countries don't.
So that if we think of the people who are currently covered by their employers, and then look at the fact that then now people with pre-existing conditions will be covered, right? That within the pool of covered people will be on average sicker. How then, for those people who are currently covered by employers, could their premiums go down?
You know, if you're talking about, well, I'll take two examples. One's the Urban Institute and the other's Retailer X. The Urban Institute, you know, doesn't matter whether you have a pre-existing condition or whatever. You come to work for us, you want insurance, we sign you up. The pool will remain unchanged. There'll be a few things that will push up costs, such as allowing my colleagues to cover their 24-year-old son who's living at home, and some of the sort of minimum standards that will push things up. But at the same time, there will be administrative efficiencies that will probably make premiums about what they are today. If you go to a big retailer who makes you wait 6 months, says we're not going to cover your asthma because when you were employed by us you had asthma already, those kinds of things, their premiums are going to go up. There's no question about it. The coverage which their employees get is going to be better. The CBO 2 days ago issued a very long and comprehensive study on what was going to happen to premiums in each of the various markets, you know, the individual market, the small group market, the big plan market. And basically it was the folks in the individual market were going to see their premium costs go up significantly, but the comprehensiveness of the insurance they were going to get was also going to go up very substantially, so they were more protected, and well over half of them were going to get subsidies that were going to make their actual payments lower. But if you were sort of an individual of average health risk that didn't get a subsidy and is uninsured now and bought a policy on the individual market, you'd probably pay more. So there's a lot of this is, you know, for some people it's more, for some people it's less, for some it's better coverage, for some it's the same coverage you had before. Yeah.
I'm a little surprised that there's anything about cost shifting in that, in response there. I don't know that.
You know, this is a huge question. You know, when we cut back payments, Medicare payments to providers, to what extent will the revenue that they're foregone, well, the hospital doesn't get from Medicare, be transformed into higher charges for private sector payers? I'm not totally a believer, I'm not a believer in cost shifting. It's an interesting concept because when you ride on an airplane, you don't say, you know, boy, there's a lot of cost shifting on this airplane. You know, what happened, I mean, every single person on the airplane is paying a different price for exactly the same product. And what's happening is the airline can segment its markets and, you know, run down its demand curve and maximize its profits that way. And if somebody, you know, if one class of folks, let's say the vacation travelers, change their demand and aren't willing to pay as much, they don't go out and raise the price of business tickets because they're already maximizing what they can get out of the business class. I mean, it's nothing they can do. And I'm not sure that doesn't apply, you know, with respect to healthcare providers. You know, we have to remember that the costs of producing healthcare in a hospital, in a nursing home, in a home health agency don't come down on stone tablets from the mount or from heaven. If I went out to a hospital and I said, and I were the only purchaser, and I said, you know, I know I've been paying you $20,000 for this procedure before, but I'm only going to pay $10,000 now. They'd do it for $10,000. Things would change, for sure. It wouldn't be done the same way. It wouldn't be done by the same people, maybe, and things like that. But you know, they do it in other countries using very different factors of production than we do.
Actually, my comment, I was really referring to uncompensated care.
On what?
Uncompensated care. Just the flip side.
The amount of uncompensated care will go down under this big time.
Right.
And so, you know, the argument, which responds to one of the previous questions, is when that goes down, the total revenues of these providers will be increased. And that should be reflected to a certain degree in the premiums of big firms and others. We'll have to do one more.
You want to take one more? One more question. Gotta be blind.
Yeah, you.
Okay, so we know that healthcare and legislation for it is pretty complicated, and for the average American, it might be even more complicated. Do you think that in terms of this, the pay or play aspect of the coverage, do you think that it's an accurate analogy to say that it's kind of like car insurance, where you have to have it, or where you're going to be paying more, or if you're going to pay for it, or do you think that's not accurate? And if not, why don't you think?
I think it's more or less accurate. The people who do the car insurance, health insurance, mandate issue say, Well, this is different. You don't have to own a car. You know, you can rent cars, you can take the bus, you can walk, you can use your bicycle. This is saying you gotta have insurance. You know, if you have two legs and, you know, breathe, you gotta have insurance or you pay a penalty. And so in that sense, it's not quite the same. The other interesting thing about car insurance, when I was at CBO, we had to go through this car insurance, health insurance thing, and it maybe has changed at this point. But it amazed me the fraction of Americans, I mean, the state requires you to have insurance in most states, who cancel their insurance. You know, they take it out and 3 weeks later they cancel it, get a refund from the insurance company, and there's no mechanism by which the insurance company notifies the state that this person, this car no longer is insured. I see many of you know this and do it. Good upstanding group of people.
Well, thank you very much.